Visible?
Yes, sir.
Yes, visible. Okay. So this is the first part is how to write your theory answers and anesthetic management of 30 years morbidly obese male posted for bariatric surgery. So always uh, my advice that you want to take it or not, I always prefer this challenges to be identified by writing these problems in this. And I feel this is useful both for writing your theory answers as well as in your practice. If you develop this attitude of identifying the problems or challenges, then it will be easy to plan your preparation, optimization, and anesthesia. So all problems associated with morbid obesity like airway includes difficult intubation as well as OSA, and comorbidities like hypertension, CAD, and reflux and all those things. Then problems associated with lap surgery, like the effect of carboperitoneum on CVS, RS, and metabolism. And sometimes nowadays they plan for enhanced recovery after bariatric surgery also. So rehabilitation and intra-op modifications have to be taken care of. Then post-op complications to avoid due to obesity as well as due to the bariatric surgery like bowel problems and other things. So the indications for bariatric surgery, say BMI more than 40 kilograms per meter square or between 35 and 40 with other significant diseases like type 2 diabetes or high blood pressure. This is recommended by the Bariatric Society itself. The second is all non-surgical measures have been tried but not achieved or maintained adequate weight loss, which is beneficial to the patient. And the person has been receiving or will receive intensive management in Tier 3 service after the procedure. The fourth is patient should be fit for anesthesia and surgery. And five, the patient should be committed for long-term follow-up also. So these are all the indications or guidelines given by the Bariatric Society. And what are the pre-op care needed before surgery is patient should be assessed with multidisciplinary team. And who are all the people who are involved in this multidisciplinary team is a pediatric surgeon, specialist nurses, a dietitian, a psychologist, and anesthetist experience in managing patients for bariatric surgery and physician. So all these people are the team forming the multidisciplinary team. And they evaluate the common synthetic symptoms of obesity like diabetes, hypertension, and ischemic heart disease. So ECG, echo, and cardiopulmonary exercise testing depending upon the patient's involvement of these systems. And assess for central obesity and metabolic syndrome, which is definitely indicative of a high risk. And obesity surgery mortality risk score OSMRS is validated preoperative screening tool for bariatric surgery, and it is used to predict the patients at risk of postoperative complications. And a score of 4 to 5 points in the OSMRS scoring considered as for postoperative admission to HTU and ICU. And nowadays in large volume centers, not all patients are taken to HTU or ICU because most of them are extubated on the table and laparoscopic procedures are less painful. Many of them are just kept in the regular PACU, post anesthetic care unit, and discharged as early as possible. Especially after an enhanced recovery program, they are discharged on the second or third day itself and ambulated the same day, and orals are started, not no catheterizations, nasogastric tube, etc. And the risk assessment of other comorbidities should be in the standard lines. And patients should be screened for OSA using stop bank questionnaire or other modalities. And patients who present with surgery with sleep apnea, minimum 6 weeks, but if the patient is in urgency, you can treat them for 2 weeks and take up and they must be instructed to bring their own CPAP machine. And patients who are unable to tolerate CPAP should be admitted to HDU setting for post-op care and support. And the airway assessment should be a thorough assessment to predict difficult ventilation and the tracheal intubation. And central obesity patients have less favorable airway anatomy. So apart from the metabolic syndrome problem, they are also prone for having a unfavorable or a difficult airway. And patients who are a high risk of they have airway obstruction risk, hypoventilation and regurgitation at extubation are all very common, especially after gastric sleeve reduction. The quantity, the chances of regurgitation are more. And increased neck circumference and Mallampati score help in identifying the patients with high risk of airway difficulties more than the BMI. Some patients with a 40 BMI may have a very normal airway, whereas patients who have 30 BMI may have difficulty because of the increase in neck circumference and Mallampati score of 3 or 2. So thorough planning of airway management and effective pre-oxygenation are very, very important. And pre-operative weight loss regimen is very useful because the low calorie diet of 800 kilocalories for 2 to 4 weeks, the patients will have their liver size reduces by 16 to 20%. And this is called the liver shrinkage diet. Any significance about this liver shrinkage for the surgeon?
Might be easier for them to access the during surgery, sir.
Fundal plication, if they plan to do the outside the procedure, liver shrinkage helps in the procedure called fundal plication or the extragastric reduction. Okay, and preoperative weight loss reduces the postoperative complication and also improves the surgical access. Now, intraoperative management of bariatric surgery. Safety briefings are very important in bariatric cases before starting each case. So confirmation of patient's BMI, anticipated anesthetic complications, adequate operation table procedure, appropriate equipment should be discussed and made available. Anesthesia is induced in the operating theater. Usually Western countries, they have a anesthesia induction room and patients are induced there and then intubated and transferred to the operating OT and put on the operating table. But because obese patients, it is difficult to do, they are induced only in the operating theater, and mostly patients are asked to self-position. They are asked to walk inside the OT and come and lie on the operating table themselves because it will avoid the strain for the OT attendants to lift them and put them, as well as avoid injuries to the patient by asking them to self-position on the operating table. And so this avoids excessive manhandling and may help avoid pressure injuries. And an inflatable hover mattress is commonly used to move the patient after the procedure. And the operating table must take extreme body weight and appropriate leg and arm board attachments have to be prepared and available. And reverse Trendelenburg position is required for surgery. And patient's legs may be placed in a gutter with foot support to stop slippage and arms placed on the boards. And the ramp position to assist airway management, and this is preferred position for surgical access also, and laparoscopic viewing. Invasive pressure monitoring is rarely required in these cases, but non-invasive arterial pressure cuffs can be used. And if you don't have the extra large size, it can be used on the forearm if the upper arm is too large. And always insert the nasogastric tube through the oral route to decompress the stomach and remove it, because especially in gastric sleeve resection, it may get caught, or in the pouch formation, this nasogastric tube may be caught. So if the surgeon feels the stomach is bloated, you insert it, suck the air and the contents, and then remove the tube immediately. And the risk of NG tube accidentally stapled into the pouch can happen. Coming to airway management in morbid obese patients, it is assess the ease of intubation and decide whether to go for conventional method or plan for awake fiber optic intubation in a much more safer way. And ramp position and pre-op oxygenation to achieve EtO2, not EtCO2, end tidal oxygen level of more than 90% should be achieved, and continuous apneic oxygenation techniques also to be followed in all cases, that is high flow nasal oxygen or Thrive, all these equipments to prolong the safe apnea period is very important in morbid obese patients. And use of video laryngoscope is helpful in successful intubation. And drug dosing is very, very important in obese patients. So suggested drug dosing are lean body weight based dosing is you take the maximum weight of a male as 100 kg and for female 70 kg. So propofol for induction is based on the lean body weight, and fentanyl and alfentanyl, morphine, non-reportation blocking agents, and paracetamol and local anesthetic are all given on lean body weight. Adjusted body weight, which is nothing but ideal body weight plus 40 degrees, 40% excess, is used for infusion of propofol or neostigmine, sugammadex, and antibiotics. And total body weight for suxamethonium, low molecular weight heparins. And neuromuscular block should be maintained during the intraoperative period. So continuous neuromuscular monitoring is useful to maintain the adequacy of blockade. Rocuronium can be used for intubation because it can be reversed with sugammadex in case of difficulty or failed intubation. Atracurium or cisatracin can be used as a initial bolus for intubation, and then you can use it for as an infusion also throughout the procedure. And ventilation is done by using a tidal volume of 68 ml based on the ideal body weight. And what is ideal body weight? How do you calculate ideal body weight? Are you hearing? Are you all there?
Yes, sir.
How to calculate ideal body weight?
Sir,
Sir,
simplified is men height minus 100. So in women height minus 105. Sir.
Height in centimeters minus 100. Okay, height in blindly don't say height. Height in centimeters minus 100 for men, 105 for women in kilograms. Okay, PEEP of 5 to 10 centimeters applied during pressure control ventilation. And multimodal opioid sparing analgesic regime with local anesthetic wound infiltration, and adjuvants as ketamine, dexmed, or NSAIDs is preferred. Desflurane is the agent of choice because of faster recovery potential. Antiemetic prophylaxis is a must for these procedures because nausea and vomiting is disruptive when you do the anastomosis in the stomach and the intestines. The types of surgery can be classified as two categories: restrictive, where an inflatable gastric band is produced, and the second is malabsorbed, where the gastric bypass, laparoscopic sleeve gastrectomy, biliopancreatic division, and duodenal switch are all done. For post-operative care, the obesity surgery mortality risk score can be used for planned post-operative care with high-risk patients admitted to high dependency unit. Avoidance of intravenous infusion, intravenous patient-controlled analgesia, urinary catheters to facilitate enhanced recovery and encourage early mobilization. Routine administration of prophylactic low molecular weight heparin and mechanical devices to prevent thromboembolism. Early resumption of deep breathing exercises and the CPAP if already in place. Review blood glucose levels because nowadays, as I said, one of the indications for bariatric is to control the diabetic state. Review and requirement of diabetic medications may be decreased significantly within the first 48 hours itself. And all oral medications to be crushed and given in a liquid form or sublingually for a few weeks after bariatric surgery until patient can resume normal tablets to be taken. And proton pump inhibitors are routinely considered for the first few weeks. And wound care and avoidance of infection is important. The early discharge with written instructions and arrangements for long-term follow-up care are important in the enhanced recovery program also. So these are all the things that I think you have to write for your theory. And coming to the management of obesity from clinical discussion point of view, these are all the common subheadings you have to know. One is, what is the definition of obesity? How do you define obesity?
BMI of more than 40 kilograms per meter square, sir.
That is the quantification, not the definition. That is grading of obesity.
Sir, also we can say that
So the definition of obesity is
body weight predominantly
abnormally high amount of adipose tissue compared to the lean muscle mass, 20% or more of ideal body weight. Okay, so this is the definition. Definition means abnormally high amount of adipose tissue deposition compared to lean muscle mass. So the medical and surgical conditions associated with obesity, system-wise manner are RS, you can have OSA, obesity hypoventilation syndrome, restrictive lung disease, and asthma. CVS, they may have systemic hypertension, coronary artery disease, congestive heart failure, peripheral vascular disease, pulmonary hypertension, hypercholesterolemia, hypertriglyceridemia, hypercoagulable syndromes, and sudden death. And endocrine, they may have metabolic syndrome, diabetes mellitus, Cushing syndrome, and hypothyroidism. GI tract, they can have non-alcoholic steatohepatitis, hiatus hernia, gallstones, fatty liver, GERD, delayed gastric emptying. Musculoskeletal, they can have early osteoarthritis, backache, inguinal hernia, and joint pain. And malignancy of pancreas, kidney, breast, prostate, cervix, uterus, and endometrial, colorectal are common in obese patients. And other things are, they may have renal failure, depressive psychosis, reduced life expectancy. Now, what is the pathophysiology of obesity? Why people become obese? There are several theories. First one is, the most common thing is the BMR, imbalance between the energy intake and energy expenditure. So energy expenditure is mainly by the BMR created by the lean tissues. That is the muscle mass activity only produces the basic basal metabolic rate. And regular exercises increase BMR and utilize the energy that you are taking. And mere fasting and dieting without exercise will not will decrease the EMR, but will result in slow weight gain because of less expenditure. And fat storage is a positive calorie balance stored as fat as adipose tissues. They are stored as triglycerides as they are efficient form of energy storage because of their high calorie density. So up to BMI 40, adipocytes only increase in their size, but in severe obesity, it may increase in number also. And the storage of triglycerides regulated by enzyme lipoprotein lipase. This enzyme is more active in abdominal fat compared to the hip fat. This is the reason why higher incidence of metabolic disturbances are associated with central obesity. When abdominal fat increases, it produces a type of what is called the android type of obesity, and peripheral fat produces gynoid type, and waist to hip ratio of more than 1 in male and more than 0.8 in female are considered a high risk for ischemic heart disease, stroke, diabetes, and sudden death. So this is how the apple and pear shape is described for men and women. And stress and cigarette smoking stimulate cortisol production, which enhances deposition of abdominal fat. Coming to the third factor in pathophysiology, cellular disturbances occur due to alteration of insulin function. There is a decreased insulin secretion due to fatty infiltration of pancreas. This is number one reason for insulin diabetes mellitus. And there is an increase in adipocytes leading to increased resistance. And how it happens is increase in adipocyte size increases the cytokines interleukin 1, 6 and tumor necrosis alpha, which decreases the secretion of adiponectin, which is a powerful insulin sensitizer. So that is the main reason for insulin resistance, decreased secretion of adiponectin. And adipocytes also secrete other two hormones called leptin, which is the hormone of satiety. And so decrease in this leptin makes you feel hungry all the time or make you eat more and more because you don't feel satisfied at all. And it activates monocytes, which decrease the capacity of neutrophils. And hormones of hunger is called ghrelin, which is modulates the appetite, increases in body obesity. So your hunger is stimulated and you don't feel satisfied. So there is imbalance between the leptin and hunger. Leptin decreased and hunger, ghrelin increased, makes you feel more hungry and less satisfied. So the genetic factors which cause obesity are there are three beta 3 adrenoreceptor gene, peroxisome proliferated activator receptor gene, chromosome 10p and melanocortin 4 receptor gene all have been identified as genetic contributors to pathogenesis of the obesity running in families, all the members of the family being obese. And hormones, the homozygous mutation in the gene responsible for both leptin and ghrelin secretion also causes the extreme childhood obesity is caused by that. And environmental factors, including high calorie foods and decreased physical activity, psychological and socio-economic factors, binge eating disorders and night eating syndromes or depression also leads to overeating. And marketing strategy to sell oversized food packets lead to overeating also. So these are the various pathological reasons for obesity. Apart from we all think it is all congenital, but there are so many other factors apart from genetic factors. Now, the various measurements used in obesity. So ideal body weight, also known as Broca's index, which is height in centimeters minus 100 for men, described in kgs, minus 105 for women. BMI, which is also called the Quetelet's index. Why it is called Quetelet's index? Any idea? Is it a person's name or it is a...
Sir, not sure, sir. This was used before in for army, sir.
Not for army, it is used for insurance purpose. Okay,
Insurance
in the
purpose, yes,
Western
sir.
countries, when insurance schemes came into practice, people who insured obese patients died much faster. So they, because of probably metabolic syndrome and other things, and the insurance companies have to pay a huge compensation or the death assured amount to them. So the person by name Quetelet, he only found out this BMI and said beyond 30 we won't insure you because the death rate is very high. So it is found out by one person who worked in the insurance company called the Quetelet. That is how the name BMI is also called the Quetelet's index. Then lean body mass is another measure used in obesity, which is ideal body mass that is calculated by the ideal body weight plus 20% of the total body weight. It's called the lean body weight. And Waist circumference more than 102 in male and more than 88 in female is also considered a measurement for obesity, especially central obesity. And waist to hip ratio more than 1 in male and more than 0.8 in female is also considered as a risk factor. Can you identify what is being done here? This picture.
Body fat percentage, sir. They're checking for the body fat
Body
percentage.
fat presentation. Somebody is pinching here something and measuring.
Triceps fold techniques.
Very good. It's called triceps fold technique measurement. What is the instrument used for that?
Appendant caliper.
Carpenter caliper. Very good. It's called triceps skin fold and it is measured using Carpenter calipers. And so these 6 measurements you have to know how they measure the grades of obesity. And what are the clinical criteria for diagnosis of metabolic syndrome? It is also commonly asked. One is abdominal obesity, waist circumference more than 102 and more than 88 in female. Triglycerides more than 150, HDL more than less than 40 in men and less than 50. HDL is a good cholesterol, so low good cholesterol. Blood pressure more than 130/85 and fasting glucose more than 110. So 3 out of these 5 criteria are considered as patient fitting into metabolic syndrome. And WHO classification of obesity and the ASA grades are patients underweight less than 20, normal weight 18.5 to 24.1 when they belong to ASA grade 1. Overweight is more than 25, again they belong to ASA grade 1. Pre-obese is between 25 to 29.9. Again they belong to ASA grade 1. When they cross 30, they become obese, but still they are ASA grade 1. Class 1 is 30 to 35, and still they belong to ASA grade 1. But when they come to class 2, which is BMI of 35 to less than 40, they belong to grade 2. And class 3 obesity, where BMI crosses 40, they automatically go to ASA grade 3. So this is the classification by WHO. What is the importance of fat distribution and how is it measured is fat distribution predicts risk more accurately than BMI. So central obesity has associated greater risk of metabolic syndrome, cardiovascular diseases, difficulty in airway and ventilation management, and overall perioperative risk. So that is the reason why central obesity is to be taken with a rate, and it can be assessed using CT or MRI. Exact deposition of adipose tissue is measured with using CT or MRI. What is sarcopenic obesity and how is it assessed? Did I ask this question?
Sir.
What is
sir.
sarcopenic obesity?
Sir, obesity with sarcopenia, sir. Coexistence of obesity with sarcopenia.
Muscle mass is reduced. So reduced muscle mass and functionality in the presence of obesity is called sarcopenic obesity. How do you assess it? What are all the clinical findings by which you will say a patient is having sarcopenic obesity?
Sir, obesity, sir, BMI more than 30 and DEXA scan or CT or MRI for the sarcopenia to be found out, and hand grip strength or other physical for physical performance, any chair stand or other tests, sir.
So it is mostly clinical. Poor grip strength, history of immobility. Patient is not able to mobilize himself frequently, and slow gait. All these 3 things are only considered as points for sarcopenic obesity. And preoperative assessment and risk prediction in these cases, the patient has central or peripheral distribution of fat, then presence of metabolic syndrome, peripheral oxygen saturation less than 90-30% are all considered as difficulty in breathing. Of course, OS MRS risk is very important. 5 factors which you have to take is, one is BMI more than 50, you give 1 point. Patient belonging to male gender, 1 point. Age more than 45, 1 point. Hypertension, 1 point. And risk of pulmonary thromboembolism, either a prior venous embolism or patient already having a breach, vena cava filter, hypoventilation, or pulmonary hypertension. So out of this 5 total scores, low risk is 0 to 1, and so the post-op morbidity is only 0.3. Moderate risk is 2 to 3 points, and risk increases, mortality increases to 1.7. High risk score is 4 to 5, and mortality increases to 3.2. And organization and equipment for this patient. The patients, especially morbid obese patients, they have to be treated with dignity, because you may not have adequate size of gowns or wheelchair and trolleys to shift them. So obese patients are mindful of social views about their size. So they may have sort of low esteem in their mind, and ensure theater gowns of an appropriate size are available, and appropriate size underwear and rooms are accessible with toilets and showers that can accommodate the patient's size and weight. Okay? Many times when they go to the restroom, there are instances where the toilet seat is broken and they are caught, they are not able to get up. So this sort of thing should not happen. And deep vein thrombosis risk should be assessed, and prophylactic measures used for all obese patients. It's a very important thing. And moving and positioning of these patients, appropriate equipment should be available to transfer the patient. That is why most of the time it is preferable to ask the patient themselves to mobilize and then come and lie down on that. So chairs, trolleys, bench and operating tables must be safe for use up to and above the patient's weight and through full anticipated range of position and movement. And whenever possible, patients should maintain their own mobility to walk to the theater and position themselves on the operating table. And gel pads should be used to protect the pressure points. And in the absence of any risk factor for aspiration, performing RSI is not a routine thing. So if they give history of GERD and repeated aspiration problem, then RSI is indicated, but otherwise it is not indicated. A few things about obstructive sleep apnea. It is defined as episodic cessation of airflow more than 10 seconds. They will usually ask this definition. How do you define obstructive sleep apnea? It is an episodic cessation of airflow for more than 10 seconds. But if there is only 50% reduction in airflow, it is called hypopnea. And if it happens more than 5 times per hour or 30 times per night, it is a of very significant thing. And stab bank questionnaire helps to identify this condition. And alternate to this is the Berlin questionnaire. OSA can be classified as central and peripheral. And the central is usually due to the stroke, drugs, alcoholism, or peripheral obesity. And peripheral is due to obesity, that is the deposition of fat in the pharyngeal muscles. Investigations needed for OSA are overnight polysomnography, complete blood count, EKG, and echo to see the cardiovascular changes. Treatment is by lifestyle modification, CPAP, BiPAP, or by surgery in the upper airway. Some people will require adenotonsillectomy or pharyngoplasty, all those things. And anesthetic risks are sensitive to narcotics, easy desaturation, and biventricular failure can happen in untreated cases with long-standing OSA. Now, stop bank questionnaire, all of you know, comprises of snoring, tired feeling in the morning, or somebody observing that patient is choking or stopping to breathe, and they have increased blood pressure. So, SNSTOP. And BANG is body mass index more than 35, age more than 50, neck circumference more than 40, and it is usually male gender patients. And based on the stop bank, you can decide how to screen the patient and how to assess the risk also. So that also can be used using the top band. And this Epworth sleepiness scale is used for patients who feel sleepy the next day because of the night disturbance. They have different types of sleeping. So this sleep study also helps in assessing whether the patient is suffering from severe degree of OSA. And the results of that are given as less than 10, 10 to 16, etc. And it will indicate the various things. And this Berlin questionnaire, again, there are category 1 and category 2. I'll go into the details. And the airway must be secured rapidly, and the duration of saturation must be increased to allow additional time for successful intubation. That is, safe apnea period duration should be prolonged so that you can safely intubate the patient. And the airway management is a challenge in all obese patients. And you should also have measures to extend the safe apnea period. And OSA with daytime somnolence is called OSA syndrome, as earlier. Vascular access may be challenging in obese patients. So you have to, because you can use nowadays vein finder. Are you using vein finder in MIA?
Yes, sir.
Yes, sir.
Okay, so you can use that for getting the vein. And volume replacement, fluid replacement is used only done on the ideal body weight, not on the total body weight. Otherwise, you will be overloading the patient. Especially patients with OSA, you have to be very careful in giving the fluids. So administer on ideal body weight places for blood loss, and based on lean body weight and not on total body weight. That is the important thing. And challenges can be remembered as a mnemonic. A prime minister at a public function. A for airway. So airway includes assessment of difficult airway as well as OSA, etc. So detailed evaluation and planning essential, including fiber optic intubation. Key position. So head up position during induction and recovery, that is ramp or head position for better viewing of the larynx. Monitors, you have to use NIBP cup size to be taken care of. EKG tracing may get a very small complexes because of the fat, so you have to place them correctly. And sometimes you may need IABP, SpO2, EtCO2, and temperature monitoring. Agents which can be safely used are drug dosing based on the various body weight, volatile anesthetic selection, and neuromuscular blocking usage. Then technique of anesthesia, difficult IV access you may have, need for central line, and wherever possible regional anesthesia will be safer than general anesthesia. But one caveat about it, in case the failure of regional, you should be able to convert it to general anesthesia. So with that preparedness, you can do regional as frequently as possible. For pain relief, careful use of narcotics, especially in OSA patients, and preferably multimodal analgesia, including regional techniques. And fluids replacement on lean body weight basis, avoid rapid filling in these patients. So these 7 points have to be remembered in all obesity patients. And lung recruitment maneuvers are done in case intraoperative desaturation occurs. So how do you do that is 40 centimeters of water for 30 seconds and use pressure controlled ventilation. Set the respiratory rate to 0 and turn off the apnea alarm. And increase speed to 40 centimeters for 40 seconds. And most recruitment occurs during the first 10 seconds. Then with hemodynamic compromise start occurring later. Then 3 consecutive size or minimum plateau pressure of 45. This is another mode of doing it. Or 2 minutes of peak pressure of 50 centimeters and keep above upper inflection point of more than 60 to 70. Or low long increase in respiratory pressure up to 40 centimeters. And step increase in pressure, that is staircase recruitment maneuver. And so this is the pressure control from 15 plus or 3, start at a peak of 10 and step up to 20, 30, 40 for 2 minutes each, then step down to 2.5 centimeters for 3 minutes. And you get a racing like this. And the reason for when you use capnography and the changes that happen, especially during laparoscopic procedure. This the picture is taken from Miller, and what are all the changes that will happen? This is very easy to identify the location of the problem. So if the patient has an endobronchial migration of ET tube because of this deep head down position or change in position, what are all the things will happen? Patient will have increased PET CO2, no. Desaturation will happen, increase in airway pressure will happen, clinical reduction in air entry, and hyperresonance will not happen unless there is a pneumothorax, and crepitus will not happen. And so you will have mainly desaturation and a normal EtCO2 in initial stages, but increased airway pressure will be there if there is a endobronchial migration. If subcutaneous emphysema happens in laparoscopy, then what will happen? You will have increased EtCO2 will be there, but pulse oximeter may not have any change. Airway pressure will not have any change, and you will have crepitus occurring in the subcutaneous region. And if it is a capnothorax, again you will have an increase in EtCO2. Desaturation will also happen. Airway pressure also will go up. Air entry will be reduced. It will be hyperresonant, and crepitus also may be sometimes felt. If it is a pneumothorax, again there will be decrease in EtCO2. Desaturation will occur. Airway pressure will increase. Air entry will reduce. Hyperresonance will be there, drum-like resonance, and crepitus may happen. Massive CO2 embolism, you will have decreased EtCO2, decreased saturation, no change in airway pressure. That is the most important thing that you have to say for massive CO2 embolism that can happen as soon as you inflate the abdomen. There will be reduced air entry in the form of murmur, hypotension, and ECV changes will happen. So this is a system-wise effect on carboperitoneum. Increase in intra-abdominal pressure increases initially the systemic vascular resistance. Then there will be compression of inferior vena cava, increase in preload, increase in arterial pressure. So initial will be rise, then there will be decrease, and cephalar displacement of diaphragm will raise intrathoracic pressure and aggravate the reduction in blood pressure. So these are all the further effects of that. And well-legged compartment syndrome may develop during prolonged surgery in a sleep condition or lithotomy position. But of course, in bariatric, it is not there. I'm just mentioning all these things for in case they say what will be the effect if a patient undergoes cholecystectomy or a procedure where you have to give a head out pill. Combination of impaired arterial perfusion in the very slow limbs cause this particular problem of well-legged compartment syndrome. Okay. We're going to know about obesity and anesthesia. Okay. So remember to mention about OSA and remember this morbidity risk score also. Are important for assessing the risk involved in these cases. And bariatric surgery, of course, post-op complications can be some bowel leak or bowel dumping syndrome. It's one of the important post-op complications, which are all late surgical problems. Of course, not anesthetic, but we have to remember these points in bariatric surgery. Those who do routinely, they have to know about all.
Okay,
Any
sir.
doubts?
No, sir.
So,
Shall we sign off then?
Thank you very much, sir.
Thank you.